Hello, today we're going to be doing the musculoskeletal exam. I've already washed my hands and greeted my patients, so we're going to move on to performing the musculoskeletal exam, starting with the upper extremity. To examine the shoulder, one of the important things is to have full visualization of the shoulder joint, and so for this portion of the exam, we're going to have the patient bring their gown down so I can see the clavicle, the acromia, and the entire shoulder apparatus. So for this, we'll undo the tie in the back, and I'm just going to ask our patient to hold her gown up while I'm examining the shoulder, and we'll do the other side as well. What I'm doing here is I'm examining both sides and making sure that there's symmetry from one side to another. Can actually come behind the patient and do that as well. We're inspecting the shoulders, looking for any asymmetry, deformity, and mass. So after inspecting the shoulder and comparing side to side, we'll move on to palpation. Remember that the shoulder, the only place that the upper extremity attached to the axial skeleton is at the sternoclavicular joint. So we'll start right there and walk ourselves out on the clavicle, looking for any abnormalities, step-offs, any areas of tenderness. We'll reach the highest part of the shoulder, which is called the acromion. Right medial to the acromion and a little inferiorly is where you'll feel the acromioclavicular joint, and we'll feel for any tenderness or swelling at that portion. The other landmark that you'd like to find a little bit more anteriorly is something called the coracoid process, and you'll feel that right here. It's a portion of the scapula that extends anteriorly. So we have the acromion and the coracoid process. Lateral to these structures, you'll find the supraspinatus insertion site and the subacromial bursa. And if there's a bursitis there, this area will be significantly tender. And then along the humerus, you'll feel for the biceps tendon and its insertion, and feel for any tenderness along that area. Next, we'll do range of motion of the shoulder. And for this, I'll still want to visualize the shoulder, but I'll go ahead and hold our patient's gown in place. And the motions that we're going to check for active range of motion will be abduction, and for this I'm going to show the patient the motion I'd like her to mimic, and that's all the way out to the side and up, okay, and then down. Adduction, in which the arm goes across the chest. There you go, and back across. Good. Forward flexion, and so from the arm starting at the side, bring it straight forward and up all the way. Okay. And then for extension, all the way down and then in back of the patient. So see how far back the arm can be extended. Good. Now, with the elbows resting at the side, you can check for external rotation and then internal rotation. The body will block any further internal rotation, so the other way to check it more accurately is to have the patient put their arm behind their back and see how far up the back the arm can extend. And you, of course, would do all these motions with on both sides and compare side to side. To the elbow, you'll need full visualization of both elbows. And first, we're going to inspect the elbow. We're looking, again, for any deformities, swelling, erythema, masses. And then we will palpate the elbow. And a few key landmarks that we'll be palpating include the olecranon process, the olecranon bursa, the medial epicondyle, and the lateral epicondyle. Next, we'll do range of motion, active range of motion of the elbow, and again, showing your patient what you would like them to do. Go ahead and flex the elbow, and then extend the elbow, and then we'll pronate and supinate. And one of the things to make sure that is always to make sure that you isolate that movement. And so having the elbow tucked at the side when you're doing pronation and supination will differentiate that from rotation of the shoulder. Okay, so with the elbow at the side, I'm inspecting the dorsum of the hand and wrist, and we'll also inspect the volar side, and we'll compare side to side to make sure that they look symmetric. And then we'll start with palpation of individual structures. So for palpation, we'll start with the dorsum of the wrist and hand, and we'll feel the wrist joint as well as the distal, ulnar, and radial surfaces. And then we'll start feeling the metacarpal bones, feeling for any deformities or step-offs and trying to see if there's any tenderness. We'll then move on to the MCP joints. The proximal interphalangeal joints. And it's best if you feel on the lateral portions of the joints to see if there's any joint effusion or tenderness. Make sure we don't forget the thumb. And then we also want to palpate the anatomical snuff box. So if you have your patient extend her thumb, you'll see where there's an indentation between the tendons. And if you press right there, you palpate. We're palpating for scaphoid tenderness in the anatomical snuff box. We'll also feel on the volar side, again, feeling for any tenderness of the metacarpal joints. So I'm going to have you do extension of the wrists and now flexion of the wrists. Okay. Go ahead and do ulnar deviation. So there you go. So moving your hands outward, and then radial deviation. Okay. Good. And now of the fingers, we'll do flexion and extension. Okay. We'll do adduction and abduction. Good. And now motions that are specific to the thumb. I'd like you to perform abduction, adduction, flexion, extension, and then next we'll move on to examination of the spine. And to do this, the patient will be standing up. It's usually the easiest way to do that. We'll have to expose the full back, and so I'm going to undo the patient's gown, the upper and lower ties, and we'll go ahead and move this over to the side so that you can see the back. And we are inspecting the back. We're looking for any deformities, scoliosis, kyphosis, any masses or lesions. Not seeing any, we're going to start with, the other thing is to make sure that we have full exposure up to the neck, and I'm going to ask that if you could use one hand to sort of pull the hair over to the side, and so we have full exposure of the neck and spine. And we'll go ahead and we'll start with palpation of the spinous processes and the paraspinous musculature, starting up at the neck and we can just go all the way down the spine. We're feeling it for any step-offs, any tenderness, any deformities, any abnormal curvature of the back. We can feel all these individual spinous processes all the way down to the sacrum. We'll also test for paraspinous musculature. So again, we're looking for any tenderness. We'll check for paraspinous musculature, tenderness on the patient's left, starting at the neck, going all the way through the back. And then we'll come back and do it on the right, starting at the neck and moving all the way down the back. Next, we will palpate the sacroiliac joints. And for this, I'm going to bring down your shorts just a little bit. The sacroiliac joints are found just laterally to the sacrum, and we're feeling for any tenderness in that area. Okay. Pull up your shorts. And next, we're going to perform active range of motion of the back. And for this, I'm going to provide a little bit of support to the gown while the patient is going to be asked to bend forward at the waist. So go ahead and bend forward as far as you can. I'm providing just a minimal support to the patient. Go ahead and come back up. We're seeing how the spine curves when that's happening. And now I want you to extend your backwards, and we're going to see how far the patient can bend backwards. Go ahead and return to normal. Make sure that you're providing some support while this is happening so your patient does not fall. The next range of motion that we're going to do will be rotation. And so for this, I'd like for you to turn to your right. And I'm stabilizing the hips, notice, so that the patient can't cheat by turning her hips all the way around. Go ahead and turn to your left, please. And same thing, I'm supporting the hips, okay? Next, we're going to check lateral bending. And so I'd like for you to just bend to your right, again, supporting the hips. And come back. And now to your left. Okay. Good. And we'll do the same sorts of motions with the neck. And for this, again, I wondered if you could remove your hair from your back. There we go. Go ahead and flex your neck. So bring your chin down to your chest. Now look up as far as you can. Okay. Return to normal. Now I want you to touch this ear down to your left shoulder. Good. And now the other way. Okay. And now I want you to touch your chin to this shoulder by turning your head. Okay. And now back the other way. Okay. So that's it for range of motion. So next we're going to have the patient walk and observe their gait as is part of the hip examination. So I'd like for you to walk across the room. I'm examining the gait, the swing of the legs, and then ask her to come back across the room. Next we're going to move on to examination of the hip, and for this, as far as palpation, you need to palpate the trochanteric bursa. And for this, it's best to have the patient on the table, and then I'm going to ask you to turn onto your left side. Continuing with the draping, I'm going to bring the drape down and the gown up. And I'm going to palpate for the greater trochanter, which is located right here. For this exam, you may need to pull the shorts down or pull them up as I have done, but you need to expose this area so you can see where you're palpating. You'll palpate the trochanteric bursa. You normally do not feel the trochanteric bursa, but if it does become inflamed and you develop a trochanteric bursitis, it is exquisitely painful. While our patient is in this position, I am going to go ahead and also check for passive extension of the hip. And so with the leg extended, I'm going to bring the extend the leg, and this is checking extension, passive range of motion of extension of the hip, and then I'll return it to normal. At this point, we would turn the patient over and repeat these same parts of the exam on the other side. Continuing with range of motion of the hip, I'm going to expose this one leg so that we can go ahead and manipulate the hip joint. Everything that we do involving the hip will involve passive range of motion, so we will check for flexion of the hip. We've already checked for extension of the hip. We'll check for abduction of the hip, and then adduction of the hip, and then bending the hip at the knee. We'll check for internal and external rotation of the hip. And you'll repeat this on both sides. Next, we're going to move on to examination of the knees, and we start by inspecting the knees. We're going to check for asymmetry, any swelling, erythema. You can also feel for warmth and compare side to side. Next, we'll move on to palpation. After inspecting the knee, we're going to begin with palpating the knee. And so you start superiorly and anteriorly, and you can palpate the patella, which is encompassed in the patellar tendon, and you can feel where the patellar tendon will insert into the tibial tuberosity. Medial and lateral of the patellar ligament, you'll feel the joint space. And so once you've found the joint space, you can extend medially, feel that joint space until you hit a fibrous band, and that is the medial collateral ligament. Attached to it is the medial meniscus that lies in the joint space itself. Any tenderness at this spot may indicate damage to one of, or both of those structures. The medial condyle is located just superiorly to this. Moving laterally of the patellar ligament in the joint space, we'll hit the lateral collateral ligament, again a fibrous band, and the lateral meniscus in the joint space, and then just superior to that is the lateral condyle. When checking range of motion of the knee, remember that we ask the patient to perform extension by straightening her. An alternative for checking for flexion of the knee is to have the patient standing up and then merely ask them to raise their heel towards their buttock. Okay, return to normal. Moving down to the ankle, we will visually inspect the ankle. We're looking for any swelling, erythema, any asymmetry from one side to the other. We will then move on with palpation of the ankle. And to perform this, we can start at the anterior aspect of the ankle joint, and we'll feel for any tenderness in the anterior aspect. Moving around to the medial side, we'll feel for the medial malleolus, feeling for any tenderness. Around on the back, we'll feel for the Achilles tendon, which extends down to the heel. And then on the lateral portion of the ankle, we'll feel the lateral malleolus. You can feel the metatarsal bones running the length of the foot. Extending down to the metatarsal phalangeal joints. And then you also want to palpate the plantar fascia. For range of motion of the ankle, we'll go ahead and do dorsiflexion, which is where you ask the patient to point their toes towards the sky. Plantar flexion, which is pointing the toes towards the ground. Inversion, which is pointing the sole of the foot inward. And then eversion, which is the opposite direction. We'll ask the patient to flex the toes and extend the toes. And that's the end of the lower extremity exam.